I'd like to talk a little bit about sort of the tradition of how bladder-sparing therapy has been in the United States, and maybe challenge a little bit of the dogma of that, and then talk about some updates from the Brits from their 10-year of their largest bladder preservation trial, and then talk about some of the newer agents that are becoming into vogue in bladder preservation and the SWOG trial that's ongoing. So really, an overview, what is the role of each portion of treatment? So in particular, what is the role of surgery? Because surgery is an avid role in bladder preservation for a number of features in the bladder preservation paradigm. In particular, talk about what's the role of TURBT, or even what's the role of maximum TURBT. I'll talk about chemotherapy, concurrent chemotherapy, and potentially neoadjuvant chemotherapy. What is that role? And then radiation therapy, to touch briefly on fractionation, why we do radiation and how are we doing it most often now. And then lastly, talk about checkpoint inhibitors, which obviously are changing the face of oncologic care. So this has now been talked, potentially not tri-modality therapy, but quad modality therapy. So this is the North American tri-modality therapy patient selection or paradigm that was pushed forward by Bill Shipley predominantly for the last 3 or 4 decades. This was, a maximal TURBT, not uncommon to send the patient back to the urologist or to, the local urologist to have an additional procedure done. No CIS, no hydronephrosis, obviously good bladder function. And then the treatment was typically a split modality therapy, combined chemo-RT with a break in the middle of treatment to assess whether there had been response. And if there had been an appropriate response, then you would complete the therapy and then do an assessment again at the completion of the therapy. So this was a good response. In part, did you have a good TURBT? And also, did you have a good response to chemotherapy and radiotherapy? So what does this do? Well, this ensures those attempting to keep the bladder are frankly low stage, and it excludes poor responders to treatment. Therefore, it's a much higher likelihood of bladder preservation, but frankly, it excludes a huge number of patients because many patients are not going to be eligible for this. And in some ways, you can say this is really an ideal paradigm for a cystectomy substitute. If you're trying to prove that bladder preservation can take a cystectomy candidate and provide a comparable outcome, this is the type of paradigm you would do. But the problem is, if you look at bladder cancer patients, there are many, many patients who are not getting any local therapy. So this may not necessarily be the best paradigm, what we've been doing in the United States, for all patients. So that brings up, what is the role of the maximal TURBT? And really, is this an important piece that's necessary, or it's an important piece that we'd like if we could get it? So, with apologies to the poet, to TURBT or not to TURBT, that is the question. Whether 'tis nobler in the bladder to suffer the slings and arrows and delays of maximal TURBT, or with haste to take arms of the linear accelerator against the tumor. And so, what is the TURBT? It's an old procedure, almost 100 years old, first described here in 1931 in the British Journal of Surgery. I do not do these, but I think, relatively unchanged over that period of time. And so, what is the most common type of bladder cancer? Well, it's non-muscle invasive bladder cancer. As we know, it's about 80% of the cases. And so what is the role of TURBT in non-muscle invasive disease? Is it good for diagnosis? Yes. Is it good for staging? Yes. Is it good for treatment? Yes. Is it good for palliation of symptoms in the bladder? Yes. But how about the 20% of patients who are non-muscle invasive? Is it good for diagnosis? Yes, you need to get histology. And to date, although there are newer things moving down the lines with urine specimens and things like that, diagnosis is still critically done by a TURBT and a biopsy, although it certainly could also, in some cases, be done in an office cystoscopy. Is it good for staging? Well, it's the best that we have right now, but unfortunately, as we know, it's not a particularly great staging instrument. It's incomplete and it's often poor. Is it good for treatment? No. In fact, it often delays treatment, and so TURBT is not a definitive treatment. If you're going to do surgery, you're going to remove the bladder, and if you're going to do chemo-RT, you're going to do chemo-RT. And TURBT is not necessarily part of that, although it has been part of the North American paradigm. And does it palliate the symptoms in the bladder? Possibly, but not necessarily. So in essence, for muscle-invasive disease and for bladder preservation, beyond pathologic diagnosis, how much value does TURBT or maximal TURBT add? So one of the comments has always been, well, patients that have maximal TURBT do better. And the problem here is there's this overlapping interplay between the stage, the size of the tumor, the extent of the resection, and the residual mass post-resection. So we know stage is prognostic. We know size of tumor is prognostic. We know extent of tumor resection is prognostic, but interestingly, those that have an incomplete resection do worse than those that had a biopsy. So it's not necessarily the resection that's there, it's those that are resectable. And if you are resectable, you have a more favorable tumor, likely a smaller tumor, likely a better stage. If you only have a biopsy, that may not necessarily be an unresectable tumor. But if you have a tumor where you attempt to resect it and can't remove it, those are the patients that do the worst. But again, that likely correlates with size and stage. And again, residual mass post-resection. So the fact is the presence of residual mass is highly correlated with the extent of resection. 96% of complete resections are without residual mass, but 66% of incomplete resections are with residual mass. But how important is that prognostically versus how important is it therapeutically? The same as Lynn looked at with patients that get neoadjuvant chemotherapy following cystectomy. The incomplete TURBT in patients that got neoadjuvant chemo prior to cystectomy was noted in those that were clinical T3, had variant histology, and had concurrent hydronephrosis. The authors of this study do note that incomplete resection was associated with a worse outcome, but the conclusion was the extent to which complete TURBT simply represents a proxy for less aggressive disease or is actually a beneficial therapeutic intervention which improves response to chemotherapy is difficult to define. So again, this is the paradigm, TURBT and residual mass. Is TURBT both diagnostic and therapeutic, or is it just diagnostic? We know that residual mass equals high stage. We know that high stage equals poor prognosis. Therefore, it does not necessarily follow that radiation should only be for patients who with no mass post-TURBT, as those patients will likely also do less well with surgery. Also, it does not necessarily follow that a maximal TURBT is needed. So at ESMO this past week, I don't have the slides to show it, they showed the bladder path trial that combined a flexible cystoscopy and MRI for diagnosis and initial staging. And what they showed was a dramatically shorter time to diagnosis by about 3 weeks. The results of the clinical outcomes from this are still pending, but it's potentially a way to do an office cystoscopy to define the histology, and then do an MRI to define the stage. And that may get you to the endpoint much faster than going back to the OR for multiple cystoscopic procedures. So what's the role of chemotherapy? Well, we've had 3 randomized trials that have looked at concurrent chemoradiotherapy in bladder cancer, one from NCIC in Canada with cisplatin, one from Great Britain with hypoxic sensitizers of nicotinamide and carbogen. And then the largest of these was the BC 201 trial with 5-FU and mitomycin. So we'll focus on the last of these. So while we're talking about the last of those, let's talk about the UK approach to therapy, and in particular the UK approach in those last 2 trials. In their hands, TURBT is indicated, but it's not required for maximal debulking. So they allow patients to go on trial that are not able to have maximal debulking, and they don't necessarily insist that it be taken. CIS is tolerated as long as it's not too extensive. Hydronephrosis was not an exclusionary criteria. They also give their therapy as a single block of therapy. So there's no midpoint assessment for a response. They go all the way through the treatment, 4 or 6 weeks of chemo-RT, and then they assess at the end, and if salvage cystectomy is necessary, do it with residual disease or do it at time of relapse. So interestingly, as a result, they view this as a mainstay of therapy for older patients, many of the patients that are currently underserved by not getting local therapy, plus as an alternative to surgery in younger patients. And in fact, it's a greater role than just a cystectomy substitute. So these are the 10-year results of the BC 201 trial that were just published a few months ago in European Urology. Local regional control was dramatically improved with a 40% reduction in local relapse with the addition of chemotherapy, with 10-year local regional control of almost 60%. More importantly, invasive local regional control was also dramatically improved with the addition of chemotherapy, with again, invasive relapse-free survival of 75% at 10 years. Overall survival was not statistically improved, although there was a slight trend here with overall survival in the range of 30% at 10 years. But bladder cancer-specific survival was improved after controlling for multiple risk factors, with a 50% bladder cancer-specific survival at 10 years when you add chemotherapy and at 41% without chemotherapy. Metastasis-free survival was borderline in improvement after adjustment, a p-value of 0.051, with about a 15% improvement in metastasis-free survival at 5 years and about an 8% improvement in metastasis-free survival at 10 years. And interestingly, their salvage cystectomy rates were actually quite low. Salvage cystectomy was only 14% in the chemoradiotherapy arm at 5 years, which is substantially higher than what we've observed in many of the RTOG trials in North America. I think it's because they don't insist upon a cystectomy for non-muscle invasive recurrence and have very detailed paradigms of how to handle non-muscle invasive recurrence, essentially handle them like other de novo non-muscle invasive recurrence, where I think in the North American paradigm it was much more common to do a salvage cystectomy for non-muscle invasive recurrence. For instance, we ran a phase 1-2 trial at the University of Michigan when I was there, and if you looked at the 7 salvage cystectomies, only 1 of those was for invasive disease. The other 6 were all for non-muscle invasive disease. So that also is important when you look at the patterns of recurrence. So here's the 182 patients for whom they had patterns of recurrence data, with about half of them having a recurrence. Local regionally, 50 out of 93 recurrences, distant recurrences, 40. Of the local regional recurrences, half of those were non-muscle invasive and could, for the most part, be handled, as you'll hear about later today, as you would other non-muscle invasive recurrences. 18 out of 53 were muscle invasive recurrences, typically handled with a cystectomy. 6 of those were pelvic lymph node recurrences. And then, 29 out of 93, so almost a third of recurrences were actually metastatic recurrences. So what's the role of neoadjuvant chemotherapy? There have been a couple of trials in North America that were very small and underpowered looking at neoadjuvant chemotherapy. There have been a couple of population-based analyses. I will say the Brits actually argue a little bit more strongly for neoadjuvant chemotherapy. They don't have the data to support it, but what they did ask was this subset analysis of the BC201 trial, is that if you get neoadjuvant chemotherapy, can that replace the concurrent chemoradiotherapy? So essentially about a third of the patients on that trial did get neoadjuvant chemotherapy. Most of it was GC. And what they found here is both for local regional control and a little bit less for distant metastasis, that there was an improvement when you added chemotherapy with the radiation, even if you had neoadjuvant chemotherapy. So I think this would fall in line with, as a radiation oncologist, what we know for patients with head and neck cancer or lung cancer, cervical cancer, that concurrent chemoradiotherapy adds value even after induction chemotherapy. So if your patient gets induction chemotherapy and they're going to get bladder preservation, concurrent chemotherapy, if they can tolerate, is still indicated. So this is a complicated figure that they put out, again, trying to address that interplay between resection of mass and residual mass and outcome. On the left is the patients on the BC201 trial that were treated without neoadjuvant chemotherapy. And what you can see is those that had no residual mass, i.e. a maximal TURBT, had better local regional control for invasive disease over the first 6 years than those who did not or who had residual mass. And in each case, adding chemotherapy provided a benefit. And then in the neoadjuvant setting, all of these curves seem to be shifted up slightly, which again is suggestive that neoadjuvant chemotherapy may provide benefit. It's also suggestive that maximal TURBT is a good thing to do, but if patients still have residual mass, a fairly significant portion of these can still have long-term disease control. For instance, those with neoadjuvant chemotherapy who got a suboptimal resection still had almost 60% local invasive disease control at 3 years. So in conclusion, for surgical management, it is critical. TURBT up front remains standard for diagnosis. Maximal TURBT is desired, but I would say it's not necessary. I would argue that patients who are not able to get a maximal TURBT could potentially still be candidates for chemoradiation therapy. Evaluation of post-chemo radiotherapy with cystectomy is needed for the urology cohorts in the room. Again, in North America, that's 10 to 15% of patients typically getting a cystectomy at the end of treatment. In the British experience, it's a little less than that. Obviously, surveillance cystoscopies are needed, and then salvage therapy over time. So I would argue that it really is a misnomer to call this non-operative management. It really is a multidisciplinary care, and urologists really are the key player throughout the patient's course. So is radiation needed? So, there have been a number of attempts to look at doing bladder preservation without radiation therapy. This is one study from Southern California that looked at 104 patients who received neoadjuvant chemotherapy with MVAC followed by a TURBT. The complete response rate at the end of the chemotherapy was about 50%. This varies as compared to the clinical complete response on the range of 70 to 80% with tri-modality approaches. And then more importantly, the salvage cystectomy rate was on the order of 66%, compared to 25% in the North American experience, and we saw more like 15% in the UK. SWOG did run a small phase 2 trial to look at this. Patients got neoadjuvant chemotherapy with gem-paclitaxel carboplatin, followed by TURBT. If they had greater than T0 disease, they were advocated to have an immediate cystectomy. If they had clinical T0 or less, they were offered observation or immediate cystectomy. So there were 77 patients. These were relatively early stage, with 70% of them T2. Neoadjuvant paclitaxel, carboplatin, and gemcitabine had a 40% clinical T0 rate, but the study failed to meet the primary objective, as in those that had a cystectomy, 60% of them still had persistent cancer in the specimen. So we'll talk briefly about radiation. How should radiation be delivered? This, in most part, having to do with daily fractionation. So again, in the United States, typically had been done twice daily radiation, which was an MGH sort of creation, and then slowly transitioned more recently to once daily fractionation. Typically, this would be once daily fractionation to something in the range of 64 to 66 gray in 30 to 35 fractions. In the UK, they had a much more standard regimen of 55 gray and 20 fractions of 2.75 gray. This analysis was not from a randomized trial. Instead, it was from those two large UK phase 3 trials, one randomizing to radiation with or without hypoxic sensitizers, the other randomizing to with or without 5-FU and mitomycin. What they did is that these were mostly radiation selected by institution, and so they pooled the analysis from these two trials and looked at outcomes for the patients that got 64 gray and 2 gray fractions, a conventional fractionation more typical of what we would do in the United States, or the patients that got the 55 gray and 20 fractions. So this is the forest plot looking at muscle invasive recurrence. The line of unity there is in red. Things to the left favor the more hypofractionated course of 20 fractions. Things to the right favor more of the conventional fractionation. And what you can see is there was about a 30% reduction in the risk of local invasive recurrence with the more hypofractionated regimen. More importantly, again, this is the outcome. I'm sorry, so the line of unity actually was the black line. The red line is the non-inferiority line. And so, in fact, the hypofractionated radiation therapy was non-inferior to the treatment with more conventionally fractionated, and in fact appears to be superior. Here, the toxicity were, again, the hypofractionation on the left, conventionally fractionated on the right. Toxicity also appears to be somewhat reduced with the 20 fraction regimen, although the overlaps with not necessarily non-inferior. So overall, I think this favors a shorter course of radiation, which is more convenient for patients and actually might be slightly more efficacious. So if we get into this concept of the quad modality therapy, what's happening in the field of immunotherapy? So I'll show you two studies that have been reported, and then we'll talk about the ongoing SWOG trial. So this was a study that was presented at ASCO last year. Patients had T2 to T4 muscle invasive bladder cancer. They got pembrolizumab for 2 to 3 weeks, then a maximal TURBT, and then they got a 4-week course of chemoradiation, so a bladder radiation course, very similar, slightly lower dose, but similar to what was used there in UK. They got twice-weekly gemcitabine based on the regimen that we had developed at U of M, and then they got pembrolizumab every 3 weeks. And then 12 weeks post-radiation, they had TUR in evaluation. Now, notably, they had an 85% complete response, which is, I think, perhaps slightly better than what we would anticipate from chemo-RT, although hard to say on a single-arm trial. It was slightly concerning that toxicity seemed to be a little bit elevated. 35% of patients had grade 3 adverse events. Now, this included the chemotherapy events, so that's not necessarily concerning. But there were grade 3 colitis, grade 3 bladder obstruction and diarrhea, and in fact, 6% of patients had grade 3 GI toxicity, and 1 had a grade 4 colonic perforation. Now, in terms of clinical outcomes, their bladder intact disease-free survival here over 3 years from the small trial looks actually quite good, at approaching 90% at 1 year, and their distant metastasis-free survival also looks promising. So I believe this is actually going forward in a randomized phase 2 trial. There was also presented from the Netherlands just recently in European Urology, this multi-arm phase 1 trial. They used a standard course of radiotherapy of 55 gray and 20 fractions. Here they subbed out capecitabine for 5-FU and still included mitomycin C. And then they had 3 different arms for immune therapy. Nivolumab at 480, nivolumab at 3 with ipilimumab at 1, and then ipilimumab at 3 with nivolumab at 1. So they ran these 3 parallel phase 1 trials. And the dose-limiting toxicities are listed here. Nivolumab at 480, they had no dose-limiting toxicities for 10 patients. The nivolumab 3 IPI, they had 2 dose-limiting toxicities from 10 patients. And in the IPI-nivolumab at higher dose, they actually had dose-limiting toxicities in 5 of 6 patients, and so they crossed that one off the board. So their follow-up was shorter, ranged between 13 and 156 weeks. Of note, they had optional adjuvant nivolumab in all 3 of these arms, and that was a very poor tolerance. I think only like 20% of the patients got adjuvant nivolumab. They had 1 muscle-invasive recurrence out of these 26 patients, and 3 non-muscle invasive occurrences, 1 in each arm. The 1 muscle-invasive occurrence, it was notable, was for a patient who had toxicity and only got 1 cycle of immune therapy and then went off immune therapy at that time. So in North America, we are a little ahead of that in that we have moved on to this very large phase 3 trial that's being run by SWOG and NRG. I apologize, I have the NRG-themed slides, but not to slight SWOG. This is a phase 3 trial of concurrent chemoradiation therapy with or without atezolizumab for localized muscle-invasive bladder cancer, the SWOG 1806 trial. So this is the schema for that. It's, again, T3 to T4, stratified by chemotherapy regimen, can be a cisplatin-based regimen or can be the Canadian regimen. Stratified by radiation fields. It actually has 3 different options for radiation fields. It has a pelvic, narrowed down to bladder, narrowed down to tumor. It has a bladder only, or it even has a tumor only. And I will say that's something I've never actually personally done, but you're allowed to just radiate the tumor and not even radiate the bladder or pelvis. In the control arm, they get concurrent chemoradiotherapy. In the experimental arm, they get chemoradiotherapy plus atezolizumab times 9 cycles with the primary endpoint of bladder intact-free survival. Seth may be able to update us on this, but I think the accrual has been very, very good. It will likely close, I think, in the next 6 months, probably a year. And this will be, of note, the largest bladder preservation trial in the world when it's completed, probably by about a factor of 2. So tremendous props to SWOG, which has really pushed this forward. So conclusions. I think tri-modality bladder preservation represents a viable but still underutilized option for T2 to T4 bladder cancer. It's critical to still also use chemotherapy, even for non-cystectomy candidates. So if you have a candidate who can't get a maximal TURBT but doesn't have a good surgical option, you can treat them with chemotherapy and radiation, with or without maximal TURBT. There are more acceptable chemotherapy regimens than the traditional cisplatin-based regimen. 5-FU mitomycin is one. It's probably the most common one. Gemcitabine is another one that's gentler for older patients with poor renal function. This does require coordinated care between urology, medical oncology, and radiation oncology. And I think we're all optimistic that newer agents, particularly immune therapy, will have an impact as we go forward. Thanks very much.